ودي مع الاساتذه الزملاء الاعزاء استاذ دكتور امل خليفه واستاذ السكر والغدد الصماء سوهاج، والزميل العزيز استاذ دكتور هشام متولي سكر والغدد الصماء قناه السويس. ويعني سعدت جدا بالسيشن السابقه، وهتسعدوا بالدخول في علم الاندوكرينولوجي مره اخرى مع عملاق الاندوكرينولوجي استاذنا الدكتور سمير نعيم، استاذ السكر والغدد الصماء ووحده الغدد بطب الاسكندريه، الاستيرويد ومشاكله، والجلوكورتيكويد ثيرابي براكتيكال اند الاسبكت اند البيتفولز. اتفضل استاذنا.
شكرا جزيلا مستر تشيرمان. شكرا لحضرتك. اسمحوا لي طبعا الساده رؤساء الجلسه ان انا اشكر الاستاذ الدكتور مصباح طبعا على الدعوه، بقيه البورد استاذ خالد الحديدي، استاذ دكتور فريد فوزي، بقيه البورد أنا على دعوتي. ده شرف كبير، وما شاء الله الحضور almost 100% يوم الجمعة، دي علامة مهمة لنجاح المؤتمر بإذن الله. For the next 15 minutes, I'll be discussing about the glucocorticoid use practical points, particularly for the junior staff. For myself, I like very much endocrinology. It's very exciting. Although for the medical students and the GP, maybe they are afraid of endocrinology. Although, if you know his physiology, if you have good reason, it's very easy. Also, a little bit of history. So, while speaking about glucocorticoids, the glucocorticoid use was introduced by Professor Henge. This is 1949, and this is the first publication, and he received award for that in 1950, the Nobel Prize for the physiology of glucocorticoid. So endocrinology is important. And still now 75 years later, we are using a lot of glucocorticoids for inflammatory disease, for allergic diseases, for autoimmune disease, even for certain neoplastic disorders with blood. And I will start by urticaria as eponym or introduction, because urticaria for us general practitioners is very important. It's the most common emergency for dermatology. And you know that the acute urticaria is less than 6 weeks. If more than 6 weeks is chronic. And the guidelines for them, for the dermatology, glucocorticoids was back in 1995, important for acute urticaria. But 20 years later, this study showed that the injection of dexamethasone didn't add much for the acute urticaria. So this is something rather new, unless the patient got angioedema. And for the chronic urticaria, glucocorticoids are allowed to be used, but only in short period, only for short period. And the guidelines for the allergology and the clinical immunology guidelines, we recommend against the long-term use of systemic steroids for urticaria. So this is very, very good. Let me move now to after this short introduction about urticaria, about the pitfalls in glucocorticoid use. You know that even small physiologic dose of glucocorticoids for a long period can lead all the complications. Diabetes. This is a diabetes conference, hypertension, osteoporosis, thrombosis. So even the physiologic dose. So we have to know that. Little bit of physiology, you see up, this is the axis for the hypothalamus, and CRF secreted goes to the anterior pituitary to stimulate the ACTH, goes to the adrenal to stimulate the cortisol and the androgen, and not aldosterone, as you know. And if you are going using exogenous steroids for non-endocrine causes, this will lead to feedback inhibition at the level of the hypothalamus and pituitary, not directly to the adrenal. It's hypothalamus and pituitary. And this is very important to know, that the suppression at the level of the hypothalamus and pituitary. When the patient is taking exogenous steroid, you can see that there is suppression of ACTH and cortisol. Once the patient stops, you can see the ACTH will rebound back, and the cortisol will lag. Why? Because the adrenal tissues will become atrophic, particularly if you are using cortisone for a long period. And after this period, you get back to the normal physiology, ups and down, the typical dynamic, more in the morning, afternoon, the rhythm for the normal physiology. And now, about the suppression. Why the suppression might last for 30 minutes, 6 hours, or 6 weeks? This depends actually on the potency of glucocorticoids, on the length or duration of use, on the dose of glucocorticoid, of course, on individual variability. And this is very difficult to predict. You have seen patients having suppression after maybe a smaller dose. But it can occur with any route. Is very important. Even the intra-articular can lead to suppression, and especially if the patient is more than 1 month. That's why if you have using steroid for less than 1 month, the guideline I will show you now say you don't need to taper gradually. This is something new. And also the low dose, the risk is very low. And this is the table to remind us, and also for the juniors, that we divide the glucocorticoids into short-acting with low potency as hydrocortisone, intermediate acting with moderate potency lasting for 12 to 36 hours as prednisolone and triamcinolone, and the long-acting with the highest potency is the DEXA and the beta-methazone lasting maybe for 72 hours. So the risk of adrenal suppression, the risk of adrenal insufficiency would be more, of course, if you are using a high dose, as you see on the left side, would be more if you are using systemic oral or injectable, would be more if you are using a high dose and using if more with 3 months. But for less than 1 month, the risk is very, very low. Of course, obese person again, and elderly person, unfortunately, they are more liable to have suppression. So remember this table, please. And when you want to taper the glucocorticoids, you've got 2 types of tapering. First is therapeutic taper. It means that if you are using it for bronchial asthma, you need to taper till the bronchial asthma is improved. But for us, endocrinology and medicine, we got endocrine taper. So you taper it down to be sure that the patient will not have 2 side effects: the glucocorticoid withdrawal symptom and the adrenal insufficiency. These are the 2 side effects. And the guidelines, again, the most recent guidelines, European Society of Endocrinology, tells us that if you are going to use glucocorticoid, whatever is the dose, less than 28 days, less than 3 or 4 weeks, you don't have to taper. So if you are going to use it for 10 days, high dose, you don't need to taper it gradually, as we are telling our students. And this is the table they put in this article. You can go to the article. I will give you the reference. So if you are using high dose 40 milligram, you diminish by 5 to 10 milligram of prednisone every week. So if using 20 to 40, 5 milligram every week, 10 to 20, 2.5 every 4 weeks, 5 to 10, 1 milligram every 1 to 4 weeks. And the most important, if you reach 5 milligrams, say for rheumatoid, many patients of rheumatoid are taking 5 milligrams. If they don't have the adrenal insufficiency manifestation, you can gradually eat it 1 milligram every 4 weeks, which is very, 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 sometimes very difficult. So what can happen if you try to stop during tapering? As I mentioned, glucocorticoid withdrawal symptom and the adrenal insufficiency. There is difference. Glucocorticoid withdrawal symptoms, that if the patient is taking 40 milligram and then you diminish to 20, still 20 is higher than the physiology. Physiology is about 5 milligram of prednisolone per day. So despite this, the patient will have the glucocorticoid manifestation. As you see, the symptoms are the same as the adrenal insufficiency: malaise, nausea, vomiting, muscle pain, the same. The difference is that the patient with glucocorticoid, they're still having the Cushing manifestation. Adrenal insufficiency, weight loss. The timing of the symptoms and signs occurs it can occur at any point with the glucocorticoid withdrawal, but of course, when you stop treatment for adrenal insufficiency. Biochemistry is normal electrolyte in the withdrawal group, while in adrenal insufficiency, you know that sodium will be low, potassium is high, and sugar will be low. And measurement of the axis, you don't need to test axis, because if you are taking glucocorticoids above the usual physiological dose, cortisol will be low and ACTH will be low. Of course, the risk of adrenal insufficiency will be unlikely because in the glucocorticoid withdrawal, because the patient is still taking cortisone above the physiological dose. That's why the guidelines say when you are when you have withdrawal symptoms with diminishing glucocorticoid, you can go back. يعني ترجع ورا, try to increase the dose back to the previous step and try again. And also you don't have to measure cortisol while the patient is taking higher dose of glucocorticoids, because cortisol will be low and endogenous cortisol, I mean the ACTH will be lower than that. Also in the guidelines site, it's very important new, is that if you want to lower the dose, you cannot do that while using dexamethasone and betamethasone because they are long acting. So we have to shift from beta to hydro or prednisone while you are going the taper. So this is a very important point to remember. And at the end, they have put this table. This is the guidelines. This is the reference. You can, I guess you can get it for free in the European Journal of Endocrinology. And they have put this algorithm. So if a patient is taking high dose of glucocorticoids and they have a high risk of adrenal insufficiency, first to shift from dexamethasone, betamethasone to hydrocortisone and prednisone. Second is that if you want to measure cortisol and you have the facility to measure cortisol, or you don't have the facility. If you don't have the facility, gradually tapering as the table I've shown you, table in our written. And then close monitoring of the patient for the manifestation of adrenal insufficiency and glucocorticoid withdrawal. And then if you have the facility to measure the cortisol, this is something else. And at the end, if you are planning to stop the glucocorticoid, if the patient is okay, and you are planning to stop the glucocorticoid, they have put this very interesting algorithm. On the right side, green, if the serum cortisol in the morning, 24 hours after the last glucocorticoid dose, is more than 10 UG per DL, you can stop it. Red, على الناحية الشمال, if it's red, you have to, if it's less than 5 UG per DL, and this is the normal, nanomole in Egypt only very rarely used, and you have to continue the replacement and try to diminish very, very slowly. If in between, you have to observe the patient, or you can do the stimulation test by giving the ACTH injection and measuring after that. And, but mind you that this cut point will differ from one country to the country, one lab to the lab. It will differ if the patient is under stress, so you need the higher dose. And also this cut-off point that doesn't apply to a patient with taking oral estrogen or during pregnancy or liver disease or nephrotic disease, because the cortisol binding globin will be altered. So this is the more bad. So at the end, they have put the algorithm. If the patient has suspected adrenal crisis, use the hydrocortisone injection, IV or IM, and followed by hydrocortisone infusion, not every 6 hours. Infusion, because the half-life cortisone is very slow. You have to give it infusion for several days and then oral. But if the patient is taking steroid, have vomiting or diarrhea, you have to give it parenterally, of course. If the patient having moderate to major stress like big surgery or acute trauma or delivery or cesarean section and so on, you have to shift from oral to parenteral. What about if the patient having minor surgery, minor stress, bit of cold? If the patient is taking more than 10 milligram prednisolone, يعني حبيتين أو أكتر, you don't have to increase the dose. When the patient is taking less 10 milligram, you have to double or triple the dose for a few days. So these are the guidelines of how to tapering and how to avoid the adrenal insufficiency in this patient. Again, you don't have to use fludrocortisone because, again, the suppression is the level of the CTH, not the adrenal. So the fludrocortisone are not useless for exogenous glucocorticoid suppression of the axis. So please remember that. At the end, Madam Chair Lady, Mr. Chairman, dear colleagues, glucocorticoids are only indicated in certain situations of urticaria. I give the urticaria as an introduction. And the long-term use can lead to osteoporosis, hypertension, and diabetes, even in a small dose. The risk factor of adrenal suppression will include the long duration, more than 4 weeks, moderate to high dose, and high potency. Glucocorticoids should be very tactful, I've shown you, to avoid the withdrawal manifestation and the adrenal insufficiency. There are two, you remember the tables. So I will be leaving. Maybe I have 1 minute of discussion, and I like this very much. It's not the answer for the question which enlightens, but it's the question. So a question is very important, not the answer. At the end, we are inviting you for Alexandria إن شاء الله في الإيجيبشن سوسايتي اوف Endocrinology Obesity زي ما تعودنا 21 23 مايو هيلتون جريس بلازا. You are all invited in Alexandria for the SU إن شاء الله. Thank you very much for your attendance.